بسم الله الرحمن الرحيم. واقفة. نبدأ الجلسة مع بعض. Great pleasure to introduce Dr. Maya Isa, lecturer of medical oncology in Armed Forces College of Medicine. She will introduce third as recent treatment option in HER2 negative hormone receptor positive breast cancer. Okay, please, Dr. Maya. الفويس بعد اذنكم. لا مش أي.
Okay. Thank you, Dr. Nihal, for your great introduction, and thank you of all chairpersons. We will talk about selective estrogen receptor degraders as a recent treatment option in advanced hormone receptor positive HER2 negative breast cancer. Planning and sequencing treatment in hormone receptor positive HER2 negative metastatic breast cancer. As we know that the first line is CDK4/6 as a standard of care, combined with endocrine treatment as aromatase inhibitor or fulvestrant, and chemotherapy in endocrine in hormone receptor positive HER2 negative. It is in a later lines as long as possible, and also in imminent organ failure. As well, endocrine treatment is the mainstay in hormone receptor positive HER2 negative metastatic breast cancer. In the second line, prior CDK4/6 inhibitor progression, we had to do a biomarker approach as BIK3CA or AKT or B10 or BRCA or ACR1 mutant, and then let's explain later in detailed explanation. Milestones in the treatment of hormone receptor positive HER2 negative metastatic breast cancer. As we see, it is a successful story of estrogen receptor pathway from 1975 of approval of tamoxifen as selective estrogen receptor modulator, then aromatase inhibitor, anastrozole, exemestane, letrozole, and then selective estrogen receptor degraders as fulvestrant in intramuscular formulation in 2002 as approved as a single line, and then combination with fulvestrant with any targeted agents as BIK3C or CDK4/6. Evolution of first-line single-agent endocrine therapy for hormone receptor positive HER2 negative metastatic breast cancer. Falcon trial studied the fulvestrant versus aromatase inhibitor and showed that there is BFS, median BFS benefit in arm of fulvestrant in non-visceral disease with 22.3 months, for which this improving the learning curve concerning patient selection and endocrine treatment drug selection as a first line. Here, new treatment option targeting estrogen receptor, which is selective estrogen receptor degraders. We should know the mechanism of action, which is blocking estrogen binding, leading to estrogen receptor degradation and reduces the transcription of estrogen receptor regulated genes. Pivotal phase 3 trials of CDK4/6 inhibitors in metastatic breast cancer. As we know that currently CDK4/6 inhibitor as a first line is a standard of care, and there are 3 drugs: abemaciclib, palbociclib, ribociclib, and was added in combination with fulvestrant in endocrine resistant metastatic breast cancer, which is Monarch 2, Paloma 3, Mona Lisa 3. And Mona Lisa 3, it was a mixed population, endocrine sensitive and with endocrine resistant, with benefit in BFS and overall survival. Let's go to this. The question is, do we have an ideal endocrinal partner with CDK inhibitor during the first line setting? There is a Parsifal study which tested fulvestrant or letrozole in combination with palbociclib, and this study doesn't recommend to upfront fulvestrant versus anastrozole as a first line. Unfortunately, CDK4/6 inhibitor had a mechanism of resistance in form of that known mechanism and unknown mechanism in form of amplification like CDK6 overexpression and amplification of cyclin D1 and ESR1 mutation, and also alteration of growth factors as HER2 activation, PI3K, AKT signaling. We should define resistance to endocrine therapy in hormonal, in estrogen receptor positive, HER2 negative advanced breast cancer as classified clinically primary or secondary. Also, we had a concept to add a definition of molecular classification, also as a de novo or acquired. Acquired, it's a mechanism of resistance occurring after prior endocrine therapy in advanced breast cancer, which is the key of this mechanism of acquired resistance is ESR1 mutation. There is a question regarding continuing CDK4/6 inhibition beyond progression. As we said before, that if in the second line we should go for biomarker approach, if negative biomarker mutation, the question is to continue on CDK4/6 inhibitor. There is ongoing randomized trials, which is maintain study, and it is a positive study that tested ribociclib and fulvestrant versus placebo and fulvestrant. But PACE study, it is a negative study. Post-monarch study, it is a phase 3 that tested abemaciclib and fulvestrant versus placebo and fulvestrant, and PFS was 5.3 to 6 months. It is a marginal benefit, but still there is a benefit to continue beyond the progression of a CDK4/6 inhibitor. Fulvestrant had a combination with targeted agent like the Capitello 291 study that tested capivastrib as a PI3K inhibitor combined with fulvestrant in patients with hormone receptor positive, HER2 negative advanced breast cancer whose disease had progressed during or after AI therapy. And the primary endpoint with PFS overall and AKT pathway altered tumors. And the PFS in overall population was 3.67.2, and also there is a benefit in the AKT pathway altered population, but FDA approval had for only the patient who had AKT pathway altered tumors. Also, we had another drug, which alpelisib, that was tested in SOLAR-1 study with patients with PI3CA mutant. That patient hadn't received the prior CDK4/6 inhibitor with alpelisib fulvestrant versus placebo fulvestrant with PFS benefit, significantly benefit. Also, there is a BYLieve study which tested patients who had received the prior CDK4/6 inhibitor therapy with benefit in median PFS, regardless or independent to an ESR1 mutation. Also had a new drug which is inavolisib, that is PI3K inhibitor, that had been FDA approval in October 2024 with palbociclib and fulvestrant versus placebo, palbociclib fulvestrant with PI3CA mutant, hormone receptor positive, HER2 negative, and progression within 12 months of adjuvant endocrine treatment completion with BFS, median BFS benefit 7.3 to 15, and also overall survival was not statistically significant but in favor of inavolisib, with adverse event like a decrease of neutrophils, hemoglobin, and diarrhea, hyperglycemia. This is the ESMO living guideline that put ESR1 mutation. If there is ESR1 mutation, we had elacestrant, the new oral SERD after fulvestrant had been approved by FDA. As we know, ER mutations is localized more in ligand binding domain with cluster of mutation in amino acid 537 to 538 in ligand binding domain, as reported in patients who have been pre-treated of aromatase inhibitors. ESR1 mutation is less than 1% in primary untreated estrogen receptor positive breast cancer, and then this percent was increased to 30% to 50% in treatment resistant metastatic breast cancer post treatment of aromatase inhibitors. Let's go to the questions. If ESR1 it's acquired mutation, is there resistant to fulvestrant 2? Yes, some ESR1 mutations results in resistant to fulvestrant, as Y537C have longer and Y537S shorter median BFS on fulvestrant. Also, fulvestrant in high dose was being enrolled in a study which is called the plasma match, that enrolled patients with ESR1 mutation with high dose fulvestrant, but it's not effective. There is a retrospective analysis was done for patients who had been received the fulvestrant versus placebo, which is Virgi, Paloma 3, and Sophia and effect study. That showed when we add fulvestrant, we had PFS and overall survival benefit than adding aromatase inhibitors. This makes us to go for the BADA-1 trial, which is a prospective study which targeting ESR1 mutation very early. We have arm 1 with first-line metastatic breast cancer with EI sensitive and hormone receptor positive HER2 negative, and to add them in EI plus palbociclib, and for detection of ESR1 mutation every 2 months. If there is arising to ESR1 mutation without any radiological progression, we had to cross over for fulvestrant palbociclib, and the median BFS was 5.7 to 11.9. And the updated of the BADA-1 study, that ESR1 mutation according to type or clonality status were not prognostic or predictive of BFS in either treatment arm. For which bare ASCO guidelines, routine testing for ESR1 mutation should occur at recurrence or progression on endocrine therapy plus or minus CDK4/6 inhibitors with blood-based circulating tumor DNA preferred owing to higher sensitivity. For which that third, which is selective estrogen receptor degraders, we had 2 drugs in different formulation, fulvestrant in intramuscular and elacestrant with oral formulation, that its advantage is higher potency and its activity in ESR1 mutation metastatic breast cancer and activity in post-endocrine treatment and post-CDK4/6 disease. There is many oral third drugs that had been evolved or developed for estrogen receptor positive HER2 negative metastatic breast cancer. And this is table summarize the whole study that was on oral third in ER positive HER2 negative metastatic breast cancer. Emerald phase 3 study design, which is a randomized trial which is phase 3 study that randomized the patients with 1 to 2 lines of previous endocrine treatment and 0 to 1 lines of chemotherapy for metastatic disease, and confirmed it to be estrogen receptor 1 mutation status, to be randomized for elacestrant 400 milligram orally versus investigator choice of standard of care, with primary BFS in all patients and BFS in patients with ESR1 mutation only. BFS was elacestrant versus physician choice in overall population with median BFS 1.9 to 2.8, while in patients who had tumors harboring a mutation of ESR1 was 1.9 to 3.8. And the overall survival was more benefit in and statistically significant for the patient who had ESR1 mutation. Also, there is a subgroup analysis for the patients who had received prior CDK4/6 inhibitor and its duration in all patients, and showed that there is a median BFS benefit in patients who had received previous CDK4/6 inhibitors more than 12 months. The most adverse events were low grade, in grade 1 to 2, with nausea, vomiting, diarrhea, constipation, and fatigue, and its accepted toxicity. For which FDA approved elacestrant for estrogen receptor positive, HER2 negative, ESR1 mutated, advanced or metastatic breast cancer. There is another oral third drugs that in ongoing trials and waiting results of it, as camizestrant, which is in Serena 2 phase 2 randomized trial versus fulvestrant, with different doses of the camizestrant in 75 milligram, 150 milligram versus fulvestrant. and showed clinically statistically significant improvement in BFS for both 75 milligram and 150 milligram doses of camizestrant versus fulvestrant, and also in patients who had detected ESR1 mutation, we had a median BFS in different doses of camizestrant versus fulvestrant, with adverse events like photopsia, sinus brady, fatigue, anemia, arthralgia, and not in grade 4 with accepted toxicity. Also, there is ongoing trials of camizestrant in combined with CDK4/6 as palbociclib versus anastrozole palbociclib. And there is another Serena 6 study which compared the CDK4/6 plus camizestrant or AI in SR1 mutant, like BADA1 trial with a switching design, and waiting these results. Also, there is another drug which is called imlunestrant, that it's phase 3, EMPER-3, that compared imlunestrant as single agent versus imlunestrant plus abemaciclib versus investigator choice standard of care with primary endpoint PFS. Also, we had another drug of oral SERD, which is giredestrant, and this study, which is called Acelera, which it was a negative study that doesn't meet PFS. But this drug was combined with everolimus in either phase 3 study design, and also was combined with palbociclib versus letrozole palbociclib, and waiting the results of these studies. This table summarizes the whole ongoing trials in metastatic breast cancer of hormone receptor positive, HER2 negative, and still evolving landscape of oral SERD in metastatic breast cancer and also in adjuvant settings. As we see, this algorithm summarize our SERDs, which is in the second line. We should go for a biomarker approach. If we have ESR1 mutation, we should go for elacestrant. If we had a BRCA, we should go for fulvestrant plus alpelisib, or AKT pathway, we should go for fulvestrant capivastrib, or BRCA mutation, or if we had a wild type, as we said before, we had a question regarding beyond progression, we should go for CDK4/6 plus changing the arm of the endocrine treatment. And also we had endocrine therapy is the mainstay in hormone receptor positive, HER2 negative metastatic breast cancer, and should be late in the chemotherapy or ADCs in hormone receptor positive, HER2 negative. And this is our home take message, and thank you.
شكرا دكتوره سعي. بصي، هو احلى حاجه الالجوريزم اللي في الاخر الملخص اللي في الاخر احلى حاجه. اني كومنت دكتور معايا؟ دكتور صبري انا عارفه. اتفضل يا دكتور صبري بعد اذنكم.
Dr. Mais, thank you. Very comprehensive question about sequencing of hormone treatment. You know that, thank you for sharing the ESMO guidelines, because it's living guidelines. In our practice over years, we CD4/6 inhibitors either with fulvestrant or with AI. We notice that the patients, we have some patients with a very early responder or progressor on the CD4/6. In the living ESMO guideline, recommended to give chemotherapy, even those without crisis. But we have actually some of patients have a very short responder to the CD4/6 within 6 months. Do you recommend to have a gene sequencing for those patients, or to start with ADC or chemotherapy without biomarker selection?
No, as we said, we had to do a biomarker or gene sequencing to go for the best treatment option for this patient who had been resistant to CDK4/6 as a standard of care in the first line.
Yes. My experience is to repeat the HER2 assessment again, because many patients have actually HER2 0
Yes.
without ultra low.
Yes.
If the patient is ultra low, he can receive ADC. TXD is the first line, keeping with breast destiny 06 now. Introducing ADC this TTZ in the first line after failure of chemotherapy for the patient with short responder to CD46.
Yes. Yes.
Thank you.
Okay.
Any other comment? Thanks, Dr.
It's my pleasure to introduce next speaker, Professor Dr. Mohammed Sabri Al-Qadi. He's the professor of clinical oncology at Shams University. His talk about update in the management of high risk early luminal breast cancer.
Assalamu alaikum. Thank you, Bahia, for inviting me. Thank you, Fresh Person. شكرا دكتورة Emmanuel for inviting me this lecture. I will talk about an early breast cancer area of debates. We know that luminal B breast cancer is not a classic way of luminal A breast cancer patients. So I will discuss today treatment challenge in the neoadjuvant chemotherapy in the early breast cancer, luminal B breast cancer in the past and the current practice in the future of clinical practice. It's my disclosure. Although the luminal A breast cancer are heterogeneous disease, there is distinct difference between luminal A and B in the benefit of chemotherapy, especially with the basal or basaloid subtype of B breast cancer patients. So they recommend us to go for subtyping. We can see that luminal B breast cancer are 20% from the luminal A breast cancer patients. Concerning the PCR, what's our subject today? The benefit of chemotherapy for the patient with early breast cancer, type B breast cancer. We know from clinical practice and many trials that luminal A breast cancer, low risk criteria, they have a dismal response to chemotherapy about 5%. When the patients we become a luminal B breast cancer, the response may be higher to 15%. And for the basaloid type, we can see the same percentage of PCR as triple negative in the basaloid subtype. So we know from the all trials, especially the Kotzar meta-analysis 10 years ago, they recommend forgo for a neoadjuvant treatment for any patient with HER2 positive or triple negative breast cancer patients. It's not an option, it's an obligation for any patient with high risk HER2 positive and triple negative disease. And it is a solid recommendation 10 years ago till now of for any patients with triple negative breast cancer or HER2 positive. It's the neoadjuvant is an option. It's not an option. It's an obligation, ethical obligation to give a neoadjuvant chemotherapy. But in the luminal B, the decision may be different. I will present a case. It is a colleague. She's a colleague for in our practice. She's a surgical oncology female patient, 39 years old, non-Egyptian, from North Africa. Presented to me 1 year ago with upper outer quadrant lesion T2 N0M0 left breast cancer with a classic luminal type B breast cancer, ER 7/8, PR nearly mostly negative, HER2 0 and high K7 40%, and she has a grade 3 invasive duct carcinoma. We did a biopsy. When you're taking with a colleague, you should be more patients, تكون صبور شوية. You should discuss all the treatment options scientifically. You should offer the standard of care for these patients and also discuss the bending updates, bending to be a standard of care when you're treating a colleague. It's a very good hard job, but you should convince your colleague about the updates and give him the best option for him. So the imaging tells us that the patient have a T2 disease without nodal affection, but little bit big tumor, T2 big tumor, over 3 centimeters with nodal negative and M0 confirmed by mammography and MRI breast. And she had a lot of questions. She had a lot of a very important question. The first one is neoadjuvant systemic treatment or first surgery, because she's nodal negative, may be practiced by a surgeon, and she's actually a surgeon to go for upfront surgery. Second question is a systemic treatment preoperatively, maybe hormonal or chemotherapy, or the benefit of the chemotherapy is any genomic biomarker to tell us the prediction of responsive chemotherapy for her case. And actually, there is any genomic profile predict a further response in the preoperative setting? And first question, neoadjuvant systemic treatment is there, either hormonal or upfront surgery after hormonal, or chemotherapy then followed by a chemotherapy. Because of she has a higher risk criteria, we not need for a genomic profiling for this patient because we have a tumor size more than 3 centimeters. She has a premenopausal patient. She has PR negative tumor. She has a grade 3 tumor. She has a high grade, high K7 40%. So the tumor biology not mandating to tell us that she needs a chemotherapy or hormonal treatment. Actually, the simple question, simple answer for this question is to give a chemotherapy as a neoadjuvant or a preoperative setting. And actually, she chose the systemic neoadjuvant chemotherapy as a treatment as upfrontly instead of upfront surgery. The next question, if the systemic treatment is there, what's to give chemotherapy or hormonal treatment? The answer coming from the guidelines, we can see that this is a last version from NC guidelines. Any patients have a high risk criteria should receive a chemotherapy in the Oncotype DX 21 gene assay. But actually, this recommendation based on the post-operative setting, not a pre-operative setting. So we know from the post-operative that she will go for a chemotherapy if 21 gene assay is not done, or the high risk criteria or high intermediate criteria. But in the reality, we have a many of genome profiling can predict. This is a last recommendation for gene suppression because it's expensive. Who to do test and which test and when to do it and the benefit of each test. We have a lot of validated Oncotype DX and MamPrint and EndoPredict and Prosigna test. Each one of these tests are answering a simple question about the benefit. We have till now the validated, the predictive test, value of the Oncotype test to tell us the benefit of chemotherapy but post-operatively. And actually, we have a Prosigna for a postmenopausal women answering the question how long to give hormonal, either 5-year or extended hormonal treatment. These are the guidelines, the benefit of test. We have CanCC, that's the 21 gene assay, is the only predictive test to predict the benefit of chemotherapy post-operative in the early breast cancer, either N0 or N1 to N3. So none of prognostic tests I have seen now predict the benefit of neoadjuvant chemotherapy pre-operatively. So the answer should be from the future, because she asked me again if there is any rule for immune checkpoint inhibitors in my case to be added to the neoadjuvant chemotherapy. So the answer should be from the future, and the revised data I found that a SPY-2 trial, the first trial discussed this issue. That's a neoadjuvant Bembro plus chemotherapy in the patient with luminal type B breast cancer grade 3 tumor may be a good treatment option guided by genomic profiling. The answer was a MamPrint. Although it is a test for testing the recurrence rate post-operatively, they use MamPrint in this study to select the patients with a responsive to chemotherapy and immunotherapy. In SPY-2 trials, they did test for all patients and correlated by the response of the chemotherapy with MamPrint, and they found the patient with a MamPrint high score, they have a good response of chemotherapy simulating the response of triple-negative breast cancer. And also they did a blueprint. It's another testing by 80 gene scoring to test the immunogenicity of the type B breast cancer, to test a response to immunotherapy, specifically Bembro for those patients. And you can see here that some PCR are totally different between high score MamPrint and low score MamPrint. We can see that in high score MamPrint in this study, the patient achieving PCR found to be of higher score MamPrint score 2, and patient have low score have a lower response rate, about 15%. This is a blueprint done to test either this tumor is immunogenic tumor to respond to Bembro or Nivo or not, and this answers a question because many patients in the luminal type B breast cancer should be classified up to 3 subcategories. Any luminal A and B breast cancer in the intrinsic factor should be classified under luminal type B or A or heteroracial or basaloid type, look like a triple negative in its response to chemotherapy or and immunotherapy. That's why we select to do this trial to convince her about the benefit of the immunotherapy plus chemotherapy. And the first trial 5 years ago documented the response of Pembro plus chemotherapy as a neoadjuvant treatment for the luminal type B breast cancer to be as a first-line treatment in the neoadjuvant setting. So to answer this question, we have a couple of trials highlighted last ESMO. We have 2 trials may change the landscape of treatment for those patients. We have a Keynote 567 and Checkmate 7FL introducing Pembro plus the chemotherapy for 8 cycles, simulating the same trial of Keynote 522 for a triple negative. The same design, but in the different patient population. And other trial, Checkmate 7FL, to introduce nivolumab plus chemotherapy in the neoadjuvant setting for the patient with weakly ER-positive tumor and high-risk luminal type B breast cancer. This is a design of the trial of Keynote 756, phase 3 trials, introducing a neoadjuvant pembrolizumab plus placebo plus chemotherapy versus chemotherapy alone for the patient with early breast cancer, high risk. You can see that's a patient population little different from the other trial. I summarize these eligibility criteria for the patients. Patients should be big tumors with N1 disease. All of the patients should be grade 3 tumor and center confirmed to be ER positive, and patient may be PR negative to be accepted in this trial, and factor to be certified against the CPS score for the patients more than 1 or less than 1, and nodal status, and patient receiving intensified chemotherapy, EC or AC every 2 weeks or 3 weeks, and ER positivity. They tested the ER positivity for those patients either low ER or ER over 10%. The study met its primary endpoint is PFS and event-free survival. So we can show the patient population of those trials. We can see that some PD-L1 patients, although it is not a criteria to choose the patients, but all the patients with this aggressive behavior found to be 75% of them have a CPS score more than 1, which means we have a new scenario for those luminal B breast cancer. We can found luminal B breast cancer with a high CPS score, allowing for more response to immunotherapy. And ER positivity, actually, more than 90% of patients has ER positive more than 10%. We can see here the PCR are higher with a patient receiving a neoadjuvant Pembro plus chemotherapy in comparison to the patients receiving chemotherapy alone. And patients with high CPS score are achieving more response to a neoadjuvant Pembro plus chemotherapy versus chemotherapy alone. And all the subgroup population of the patients are actually had a response even disregarding the PD-L1 status. We have a same scenario of Keynote 522 in the triple-negative breast cancer. Whenever you have an immunogenic tumor responded to immune therapy and with aggressive behavior, may be accompanied by genomic profiling to confirm that the patient, that the tumor is a highly responsive to immunotherapy. You can give Pembro or Nivo in addition to chemotherapy, and you have a double of the PCR for the patients. The anemia is a little bit hard actually in the pediatric arm receiving Pembro plus chemotherapy, but it's a bit no grade 3 to 4 toxicities. Conclusion for this trial that the patient receiving Pembro plus neoadjuvant chemotherapy have a doubled PCR rate than the patient receiving a neoadjuvant chemotherapy alone. And we have another trial with Nivo plus chemotherapy. We have actually combining nivolumab plus chemotherapy for 8 cycles in the neoadjuvant setting. And the same criteria, they confirm that ER positive tumors, all the patients should be a grade 3 tumor and should be ER more than 1%, and with grade 3 tumor or grade 2 with ER positive between 1 and 10%. And also factors certified against the PD-L1 by CPS score 142. It's allowed for Atezo and for Nivo to testing the immune response for the patients, and also the grading and also nodal disease. We have these also the same criteria of the patient distributed equally between two arms, and actually we have a double of the PCR rate for the patient receiving Nivo plus chemotherapy, either for all population or the patient with PD-L1 CPS score more than 1% or TPS score more than 1%. But in this trial, the higher rate for the patient achieving immune response rate more than 1% doubled the PCR. So Nivo is preferred to do a PD-L1 for those patients to have a good response with Nivo plus chemotherapy. Actually, the response is there, but higher for the patient with a PD-L1 score more than 1%. And this is the criteria actually distributed equally between both of arms in the trial. And back again to our case. Based on two trials, her question was just about after 1 month after the last ESMO, she asked me specifically about the benefit of adding of Pembro to chemotherapy in her case. And actually, I encouraged by this discussion to add Pembro plus chemotherapy for her case. Actually, she finished 8 cycles of the Pembro plus EC and Pembro plus paclitaxel, and fortunately, we found that after 4 cycles of EC plus Pembro, we have near complete radiological response confirmed by MRI and PET-CT. So patient finished her adjuvant treatment and did a lumpectomy. Unfortunately, we have a PCR for this patient. We have a complete pathological response for a luminal type B breast cancer. It is not commonly seen for the luminal A, but maybe frequently seen with this behavior of tumor with luminal B breast cancer. So another question, what's our go to go for adjuvant treatment for this patient? Do you give AI only, or to give AI plus Abema, or to give AI plus ribociclib? The answer is yes. This patient indicating to receive CD46 in the adjuvant setting for her breast cancer because she has a high risk N0 disease. Maybe this criteria fitting the Monarch trial or the Natali trial, but this trial is fitting more for the Natali trial. We have a high risk luminal type B breast cancer, grade 3 tumor, and high 7 and high genomic profiling for the nodal disease. And we have a 2-player in the game now for the adjuvant CD46, either abemaciclib for real clinically pathologically risk of ER/PR positive HER2 breast cancer, or the patients with ribociclib in Natali trial can give ribociclib for the high nodal disease and also nodal negative disease with high risk. We can see this not a comparative between trials, but our patients taking the place for a Natali trial, not for abemaciclib, because by data from abemaciclib, she cannot receive the Abema, but by data from Natali trial, she have T2 disease, N0 disease with a grade 3 tumor and high genomic risk criteria. So she's fit for, last question, she's fit for AI plus ribociclib for 3 years for 400 mg per day for 3 years in adjuvant setting. So finally, I answered all questions for my colleague, and to my conclude, in one SPY2 trial, Pembro plus neoadjuvant chemotherapy alone improved estimated PCR rates from 13% to 35% in patients with MammaPrint immune score 1 or 2. And in my conclusion here, in high risk luminal type B breast cancer, clinical and pathologically, criteria grade 3, weak PR negative, N2, N3, T3, T4, N0, or high risk genomic criteria, the additional Pembro plus Nivo or Nivo plus chemotherapy may be the future recommended treatment for the luminal B breast cancer. All the questions answered finally, alhamdulillah, and thank you for your patience. Thank you.
Thank you, Dr. Muhammad, for your excellent presentation as usual.
Thank you. Thank you.
Next question for Dr. Muhammad.
Dr. Radu.
But if there is any opportunity to maintain with the immunotherapy after the neoadjuvant chemotherapy plus immunotherapy?
A very good question and very smart question, because in the 7FL trial, they designed the trial to give immuno pre and post. And also in the trial keynote 756, they designed the trial to give Pembro plus chemotherapy, then surgery, then continue 1 year for Pembro for the patients. At this time, the data released from Marquette trial to give obligation to give abemaciclib for the patient in the adjuvant setting. That's why they omitted the post-operative Pembro and Nivo on those patients, because they have no safety data to give ribociclib plus Pembro or Nivo plus ribociclib or abemaciclib. That's why the event-free survival for those trials are omitted, because they cannot achievable, because they didn't give Pembro for some patients, because many patients preferred to start abema and ribociclib as an adjuvant treatment, and they have no safety profile in the trial designed before release of Marquette trial to give Pembro plus abema. So the crowdness of data for the how to give in adjuvant setting preventing them to continue Pembro or Nivo post-operatively. So I could recommend to have many trials to answer this question, but in those trials, they just have a PCR to know that the patients with urinary type B may have a PCR in the way of triple negative disease or HER2-positive disease, and you can expect a PCR for those patients. But the PCR translated to event-free survival or OS benefit, like triple negative or HER2-positive, not yet answered.
Thank you so much.
Thank you. Thank you.
شكرا محمد.
It's my
دكتور سعيد اتفضل.
استاذ دكتور محمد استاذي، هستاذن حضرتك سؤال بسيط. This patient
الصوت بس دكتور سعيد.
radiologically negative, nodal negative.
Yes.
And they did sentinel lymph node after neoadjuvant. This is the classic scenario for our patient after neoadjuvant. Did we need to do at first biopsy from the negative lymph node if we decided to sentinel later on? Or this is a common scenario to do sentinel after neoadjuvant?
Yes. I think the high frequency ultrasound answers the question now, because in trials in the radiotherapy, they did a high frequency ultrasound in the axilla. It is free by high frequency ultrasound and MRI. They cannot do any fine needle. If they have any measurable disease in the axilla, they will do a fine needle and take a biopsy. But even if the patient with N1 disease, she's fit for what I said, a combination of chemotherapy plus immuno, if taking in the future. But in the current practice, these patients, if she has a luminal breast cancer, high risk with nodal negative, the surgery is an option, and to give a chemotherapy is an option. But I prefer to enjoy the preoperative chemotherapy to have a down staging for the tumor and have early systemic control for those type of breast cancer, especially with the basaloid subtype. It looks like a breast cancer triple negative in its behavior. So we are doing with tumor with a very aggressive behavior, especially if you are going to do intrinsic subtype, you can find a breast cancer likely acting that triple negative pathway. So I think preoperative chemotherapy, even with patients with nodal negative, will be with good value for those patients, because actually they will receive adjuvant chemotherapy after surgery. Thank you.
It's my pleasure to introduce my dear colleague and friend, Dr. Sarah Shams. lecturer of clinical oncology from Kasr Al Ain University, Faculty of Medicine, Cairo University. She will talk us about the evolving role of ADC in advanced luminal breast cancer. Dr. Sarah, please.
Good evening, everybody. I'm very happy for this kind invitation. As has been discussed previously with my dear colleague Dr. May and my dear professor Dr. Sabri Al-Adi for the treatment line in metastatic breast cancer, luminal disease. Now we're going to explore more options for these subtypes of the patients, the luminal subtypes. Can we offer others options by exploring more deeply in the pathology of the disease? As we know, the luminal disease usually consists of ER and PR positive disease. Besides that, there is an HER2 negative disease for this. Current classification for the HER2 and the breast cancer constitute mainly for the immunohistochemistry expression for HER2. Either it's HER2 negative or HER2 positive. In our luminal disease, it's an HER2 negative disease. That's it. This classification usually depends on if it's a circumferential membrane staining complete instance in more than 10% of a tumor cell, so immunohistochemistry will be positive 3. Weak to moderate complete membrane staining, it will be a positive 2 and will need a genetic further investigation. And incomplete membrane staining, that is a faint or barely immunohistochemistry plus 1. So in our luminal disease, if we have the immunohistochemistry plus 1, can we further investigate this? No staining observed, meaning immunohistochemistry 0. The breast cancer subtypes, the usual defined breast cancer subtypes is the hormone receptor positive, which constitute 68% of the disease, and the triple negative constituting 10%. HER2 positive disease and hormone receptor triple positive disease constitute 10%, and the only HER2 driven disease 4%, meaning that the HER2 positive will constitute only 15% of the breast cancers. The spectrum of this HER2 expression for breast cancer, meaning there is amplification with benefit from the therapeutic inhibition, and only in the hormone in HER2 positive disease, not an option for HER2 negative disease. Can we and as a TDX1 and Destiny Breast 01 trial for HER2 positive disease only? Can we further define a spectrum of the subtype not only for the luminal or HER2 negative or HER2 positive disease? HER2 low breast cancer will constitute 45% to 50% of the disease. HER2 positive breast cancer will be only 15%, and the HER2 negative 30 to 40%. And we can target for in the Destiny Breast 04 trial for those patients whether HER2 positive one. ADC or TDXD, the drug and neutralizations for the TDXD lead to release of the payload and subsequent cell death to the target tumor cell and neighboring cell via the bystander effect. Meaning that we have and target the HER2 receptor, we can, with a drug that have a linker with a topoisomerase, we can ensure the delivery for the chemotherapy so it can enter the cell and causing the cell death with the bystander effect, the membrane permeability to the neighbor cell. This can explain the results we cannot explore in the next slide. Destiny Breast 04 TDXD versus chemotherapy for previously treated HER2 low APC. This was a multi-centric randomized open-label active controlled phase 3 trial. Destiny Breast 04 it targeted the patient whether HER2 low. HER2 low, let me revise gains, HER2 low meaning that there are ER or PR positive or triple negative, but there are HER2 low immunohistochemistry plus 1 or immunohistochemistry plus 2 and negative bisesh. The unresectable or metastatic, they received 1 to 2 lines of the chemotherapy in the metastatic setting of or recurrence more than 6 months after adjuvant chemotherapy. And for the hormone receptor positive was the case, and our lecture, we're gonna to have to receive one of the endocrine therapy, and they have a stable brain mets eligibility. Number of the patients, there was 557 patients, and they were randomized to TDXD 5.4 milligram per kg every 3 weeks. A number of the patients was 373 versus the chemotherapy 184 patients. This trial primary endpoint was the progression-free survival in a hormone receptor positive disease, and the key secondary endpoint tested hierarchically was the progression-free survival, overall survival, and the overall survival for all patients and the hormone receptor positive. Additional secondary endpoint was the safety. TDXD triples the overall response rate versus the chemotherapy. And in this trial, there was a hormone receptor positive patient and others hormone receptor negative. Our lecture here focusing on the results for the hormone receptor positive. There was an overall response rate 52% versus 60% for the chemotherapy arm and the hormone receptor positive disease. The TDXD overall response rate for hormone receptor positive disease was with the clinical benefit for 71% versus 34% for the chemotherapy arm. Destiny Breast 04 overall disease-free survival for all patients that categorized as hormone receptor positive or negative. There was a 9.9 progression-free survival versus 5 months for the chemotherapy arm, as have been showing in this curve. There's a benefit of 4.8 months for the all patient. For the overall survival, there was 6 months benefit for the all patient, 23 months versus the chemotherapy arm, 16 months. If you're gonna to speak about the hormone receptor positive metastatic breast cancer, as mentioned by my colleague, there's a different lines for the treatment. The first line was of course, the endocrine therapy, achieving with the CDK4/6 inhibitor for 28 months with the CDK and the hormone receptor. The second line usually is achieving 16 months with the CDK or hormone receptor in the second line, or if we can offer mTOR inhibitor with the hormone receptor or a PI3K inhibitor. And the third line was declining the survival 6 months benefit with chemotherapy. Can we offer for this heavily pre-treated patients, the hormone receptor metastatic patient, can we offer more options by exploring deeply for their HER2 status? Destiny Breast 04 progression-free survival, especially in the subgroup of a hormone receptor positive, showing that the patient progression-free survival was 4.7 months. Again, it was 10 months versus 5.4 months for chemotherapy. Again, there was a benefit in the overall survival for this patient, 6.4 months, gaining from 23 to versus 17. All subgroup for hormone receptor positive had showing the same progression-free survival with the benefit either those who received previous line of chemotherapy or CDK4/6 inhibitors. The other subgroup was the hormone receptor negative. It also showed a benefit, but we're gonna talk at another session. Yeah. What was the most common drug related to adverse event for the patient receiving ADC? If we can go back to the structure for the ADC, we can imagine that with this very good response for owing to the targeting for HER2 and the permeability and the high effect and potentially for the chemotherapy, but there is expected side effect from those anticoagulant drug therapy. Those mainly are the vomiting or constituting 34%. And how can we manage and treat the ADC's drugs? Evaluation, this is going to be by our clinical practice. Evaluation test by baseline, like CPC dose differential or platelets, creat, total bilirubin, ALT, all will going to be required. The echo as a baseline for any ADC that targeting HER2 also will going to be required. Prior each dose, we gonna repeat this routine lab test. The echo are going to be repeated every 12 weeks. Like any anti-HER2 drug therapy. What we can expect and how can we manage the side effect for ADC? According to the NCC guideline, the TDXD is associated with is a highly emetic risk. more than 90% frequency of emesis, recommended using an anti-emetic protocol. The high anti-emetic protocol, which all we use in our clinics, is the treatment option preferred using the 4 lines for anti-emesis, the olanzapine and aprepitant, the Ordexa and the Ondolans. The patient education should be initiated before and continued through the TDXD treatment. It's a very cornerstone for the patient treatment with the ADC to educate the patient what to expect, especially with the incidence of pneumonitis as a side effect. We can explain the sign and the symptom for pneumonitis, interstitial lung disease and pneumonitis. We can educate the patient that any new onset of cough or fatigue or change in their exercise tolerance, they should be requested to report immediately. And there's a lot of options that we can offer for with this interstitial lung. If we are suspecting interstitial lung pneumonitis, we can firstly we will stop the drug. We can use the steroids and antibiotics. We can monitoring and hospitalize with oxygen therapy and mechanical ventilation if needed, and drug dose reduction for further cycles, or discontinuation could be an offer if we as appropriate grade of the toxicity. Again, so if we go back to the lab, to the pathology, is there an option that we can rebiopsy our hormone receptor positive disease so we can offer this treatment? There's a data about discordance among the pathologists between the HER2 immunohistochemistry 0 and the HER2 immunohistochemistry +1. In a recent study among 18 experienced pathologists, there was only 26% concordance between the diagnosis of HER2 immunohistochemistry 0 and HER2 immunohistochemistry +1. Of importance, HER2 0 doesn't mean absence of HER2, as it also includes tumor with ultra low expression. There's also discordance even within one organ within a patient, like this data that result of 5 to 6 of the patient had heterogeneity of the HER2 status from different segments of the liver. This meaning that we can, if we are looking for options for our patient with exhausted lines of the treatment, we can offer her a new biopsy that can offer her a treatment option if it's a HER2 low. Instability of HER2 low breast cancer, multiple studies have demonstrated instability of HER2 low expression from primary to metastatic breast cancer. Also, the reason for this unclear. It may be multifactorial, involving pre-analytic factor, heterogeneity in HER2 expression, or biological disease evolution. Instability of HER2 low breast cancer, the primary breast cancer versus the matched, the primary versus the different immunohistochemistry from the biopsy from the metastatic disease. What we can do for future direction, TDXD demonstrated clinical activity in HER2 0 as a DAISY trial, and potential clinical activity as first-line chemo, and in HER2 ultra-low destiny breast 06. The complexity of HER2 low pathological definition and the activity of a TDXD even in HER2 0 MPC suggest need for a quantitative biomarker, improved detection of the HER2 0 and HER2 ultra low, identifying who would not benefit from a TDXD therapy as a treatment option. Destiny breast 06 TXD and chemotherapy naive HER2 ultra low advanced metastatic breast cancer. This trial will a randomized open label phase 3 study trial. The patient with advanced metastatic breast cancer with progression into previous endocrine therapy restricted to a hormone receptor disease. This trial will offer for the HER2 low by immunohistochemistry +1 or +2, or HER2 ultra low immunohistochemistry 0 or +1 based on central immunohistochemistry assessment at the diagnosis of first metastatic disease or later. Number of the patient was 85 patients. TDXD representing 425 patients versus the chemotherapy until progression or progressive disease or toxicity. This trial will offer for the patient with a HER2 receptor positive disease with ultra low or low treatment option, especially in later line. Thank you.
Dr. Sarah, quick question. Dr. Sarah, do you prefer to double check of HER2 because of this new data of indication of HER2 in low HER2 or 0?
Of course, the treatment option for the luminal disease, hormone receptor positive, we is still the CDK4/6 inhibitors, as it offer her at 24% in the first line. But I'm talking about the subsequent line for those patients who gonna be exhausted from the other from the hormonal therapy or the chemotherapy. Can we offer them this TDXD? Of course, but with the double check for the HER2. This could be by not only for revising, we can offer a new biopsy from metastatic disease, or during the treatment, new biopsy in the setting of the first onset of the mets, or in later if there is a discordance or there is a evolution of the disease.
Thank you so much. Is there any question
Yes,
from the floor?
Dr. Sarah. Thank you for elegant presentation, and thank you for highlighting the adverse events of TDXD, because it may be serious in some patients. Last ESMO, they announced for 5S for any patient receiving trastuzumab TDXD. Firstly, to screen, because many patients may be transmitted from grade 2 pneumonitis to grade 4 fatal pneumonitis. And secondly, to do a scanning. The CT scan without contrast may be very comprehensive imaging to see the pneumonitis very easily. And synergy, to have accompanied with pulmonology to assess the pulmonary function test, which is maybe declined during pneumonitis, and stop treatment, and lastly, using steroids for the patients. And I think 5S may be a more comprehensive abbreviation what's going to do for the pneumonitis, because the steroids may be life-saving for those patients. Thank you.
Thank you, doctor, for this time. Thank you so much.
Thank you so much.
Now we move for next speaker, Dr. Shaima Alashin, Assistant Professor of Clinical Oncology, Qasr Al-Aini. She will talk about treatment option of ER-low early breast cancer. Please, Prof. Shaima.
Thank you very much for the very lovely introduction. Thank you, Dr. Amani, and the whole team of the. Okay. Thank you very much, Dr. Amani, and the whole team of Bahia. It's always a pleasure and an honor to be in yet another one of your conferences. And it's always a pleasure when you give me very difficult assignments every time you do that. So this time I'm given the duty of delivering some info to you about ER-low breast cancer. And the question is there any consensus? And I think it's very easy. I can tell you there is none, and be done and tell you thank you. Okay. So first of all, just to remind ourselves, as you know, that hormone receptors, we have always understood the deep connection between breast cancer and hormone receptors ever since the identification of breast cancer, and the idea that oophorectomy somehow improves the disease. But the definition and the introduction of hormone receptors in practice was not before 1960s with the Arler team. And ever since then, hormone receptor status has been a pivotal, has had a pivotal role in the decision-making algorithm for breast cancer. Now, ER-positive disease, of course, as you know, is the most common subtype. 70% of breast cancers are hormone receptor expressing, and it usually harbors the more favorable prognosis, and we've always had a prognostic implication of hormone receptor expression. And ever since the introduction, of course, of tamoxifen and later on other hormonal manipulations, we have had also the predictive implications of hormone receptor expression in breast cancer. Now, this is just a quick reminder of how we go testing our scoring ER expression in hormone receptor in breast cancer. We have always had the old, I don't know if there's any pathologist in-house, we've always had the old algorithm scoring system. And this is a system of two factors, the intensity scoring and the proportion scoring. Proportion scoring 0 to 5 depends on the percentage of breast cancer, reminding you that 2 is where 1 is more than 1% and 2 is 1 to 10%. 0 to 3 is according to the intensity of expression of the receptor. While the CAP guidelines, which is endorsed by most guidelines, just uses the percentage scoring. This is not very easy, and ever since the introduction of the CAP guidelines, 1% has been used as a cutoff. okay, what is the real threshold for positivity and when can we say this is ER positive? I have to say this has been a game of ball, and the ball has been with the pathologists for quite some time, where in 2010, this is the ASCO recommendation for in 2010, telling us, please, if you're going to use the CAP scoring system, once you have a 1% expression of estrogen receptors in your cells, this is quite enough to define your tumor as ER positive disease. And since 2010, all those reporting their pathologies through the CAP recommendations will use 1% as a threshold to say that this is ER positive disease. And then, again, the ball is still with the pathologists. In 2020, they came back and told us, okay, oops, it looks like 1% is not the best way to go. And now they tell us, okay, 1% is a threshold to say that this is ER positive. However, 1 to 10% is not really ER positive. And please write a comment at the lower at your reporting system to say that this is ER low disease. And they introduced this definition of ER low using a 1 to 10%. And then now the ball is thrown at the oncologists and go ahead, see what you're going to do with this new definition of ER low. This has been since 2020. Now, bearing in mind that only 5% of breast cancers are within that domain of ER low disease, and PR has been out of these definitions because ever since the Sanganer recommendation of using 20% cutoff just to define the low proliferative luminals from the high proliferative luminals, we have not been hearing a lot about the PR when it comes to decision making. Now, does this have any, let's start with the prognostic implications. Is there any prognostic implication for having ER low rather than ER strongly positive breast cancer? And I think anyone treating breast cancer, we have always been under the impression that yes, it makes a difference. And we have always been looking into the degree of hormone receptor expression. And we have always had this inkling that the more there is estrogen receptor expression, the more the disease, it will be hormone sensitive and will have a more favorable outcome. And this has been reproduced in each and every trial that was looking into hormone receptor positive breast cancer. As an example, I'm showing you the text in the soft trials, which will show you that using even a cutoff of 50%, even 50%, that much of a high cutoff, the below 50% are doing worse than the above 50%. Same goes for PR. Okay. Now this study, I'm showing you this study. This study is a very nice study that was run by the Nottingham Group in UK, and they included I think something like 4,000 patients, and they were looking at different cutoffs for ER positivity, and they were using percentage as per the CAP guidelines, and they were using what's called the H index, which is a score that is somewhat similar to the Aldrich score, where they multiply the percentage by the degree of expression, 1, 2, or 3. So it's now 0 to 300, okay? And as you can see, 0 to 9% is the blue curve, and they have the most dismal prognosis, while the 100%, they show the best prognosis. They even have a curve that is higher than the 50 to 99. So yes, the idea that we have always been under is that the more expressing of hormone receptors the disease is, the more the disease is responsive to treatment, and the more favorable prognosis the disease is. Okay. Now this is one of the biggest real-time data we have for ER low disease. It comes from the German guys, the Munich group, with the data set of about 38,000 patients, and they have data for 15 years. And they were looking, here they segregated the disease. Okay, ER low, this very low expression of 1 to 9%, they are the worst among the luminals. Okay, and what about the triple negatives? Is it more like triple negative, or is it better than triple negative? So I decided to get you this publication because it has the 3 curves for the 3 diseases: ER low, ER more than low, intermediate or high expression, and triple negative breast cancer. So first of all, look how similar it is to triple negative, even regarding clinical pathological data. For age, they have a much lower age. There's a significant difference in age, median age, between the ER low, triple negative, and ER positive. And for grade, almost 70% had grade 3 disease when they are ER low or triple negative versus 19% if they are hormone receptor intermediate or high expression of hormone receptors. Does this translate into clinical outcome? Yes, definitely. These three curves show you the green curve is the high expression, above 10%. The blue and the red curves, the triple negative and the low expressions. And as you can see, the left-hand side curve is for time to local recurrence, a total caption of the curves between triple negative and ER low. And for the time to distant metastasis, it's the same. A very obvious separation between hormone receptor positive and hormone receptor low towards the triple negative. This, of course, understandably translates into overall survival data, as you can see. What about real-time data about the response to neoadjuvant chemotherapy? This Swedish trial included 5,000 patients with ER low and ER negative or triple negative breast cancer, and the upper curve is for the whole population, and they show you what we already know, that the PCR patients have a much better prognosis and outcome compared to the non-PCR patients. This is for the whole population. If you look down, the B curve is for the PCR, whether ER low or triple negative. So if you achieve a PCR in ER low, you will have the same outcome expected and the same improvement expected as in triple negative breast cancer, while the C curve is for the non-PCR, and again, triple negative and ER low seem to be having the same outcome, the same dismal prognosis if they do not achieve PCR. So now let's take this, what we know. This is what we know actually. We have some pathological discrepancies, and we have a lot about prognosis. And now we have to go to the clinic, and I have a patient with ER low disease, and we start the head scratching. What should I do with the patient with ER low disease? Now, some time ago, this patient would have been categorized as a luminal B disease, just similar to the patient Dr. Sabri was presenting in his lecture. But now, with the introduction of ER low, we are all under the impression that, okay, maybe I should be treating this patient more like a triple negative breast cancer patient. So I have a few clinical tips just to remind you and myself. Let's not put clinical sense out of the question. So for example, if I get a patient in the clinic and it is a metaplastic breast cancer, and they tell me it's ER low, I think you just need to turn your head to your pathologist, and they will acknowledge right away there is no such, almost always, metaplastic is triple negative. You can rerun your test, you can do a rebiopsy, it's triple negative. On the other hand, on the other side of the story, if I get a mucinous breast cancer, and if they're telling me it's ER low, I will have a very hard time believing it's ER low, and I will spend some time to redo a biopsy and look again, because it's very rare to have an ER low or an ER negative expression in mucinous or in the more favorable pathological subtypes of breast cancer. So this usually helps, okay? I have some other tips that we can discuss later. Okay. Can gene expression profiling help us? Dr. Sabri elaborated gene expression profiling and its role in luminal B breast cancer and how we can put in use. So if you are in the clinic and you have ER low expression and you think, okay, maybe it's luminal B breast cancer, why not do a gene expression profiling before I overtreat this patient? So we have a lot of data, and this is one of the nicest, not very big numbers of patients, but look what happens when you take these patients and run them through an Oncotype DX. Almost all of the patients, 100% and 100% and 84.6%, almost all patients will have a high recurrence score above 26. Okay, similar data are represented with the PAM50. Almost in all PAM50 runs, at least 70 to 80% of these patients will show up as a basal type of breast cancer. Okay, so actually, if you ask me, I will not put a lot of money doing a gene expression profiling for this patient. I will save my money for the less aggressive patients, the patients who have an apparently luminal A or not a very highly proliferative luminal B, and then maybe see how she can benefit or not from chemotherapy, but not for the ER low. So I don't think gene expression profiling is where we should put our money. Let's go see what we can do about treatment. So for the guidelines, this is the only mention we have of ER low in the guidelines. Okay, this is the NCCN guideline, the 5th version of this year. This statement has been there for the last 3 years, I think, or 4 years. What it tells you basically is, okay, 1 to 10%, guys, this is low, ER low. maybe they benefit from endocrine therapy, so do not put out the endocrine therapy very easily. But by the way, they behave like triple negative breast cancer, so try to treat them like triple negative breast cancer, and then they run away and they don't give you any much to run with. By the way, this is not really applicable in clinic, because if you are for example, if you have a patient living abroad under a very tight healthcare system, you cannot actually get an approval for pembrolizumab in a patient with ER low. You cannot easily get an approval for CDK4/6 inhibitors unless it's really high risk. We'll discuss that. So actually, in practice, I cannot take these words from the NCCN guidelines and treat the patient. So first of all, first question I think is the easiest question. Should I give the patient neoadjuvant treatment or give her an adjuvant treatment? I think even Dr. Muhammad told you a bit of an aggressive luminal B, we would go for neoadjuvant treatment. This is even most probably will be more aggressive. And as we've always known, ever since the Cortazar and the FDA meta-analyses, that neoadjuvant chemotherapy gives us the PCR piece of info, and the PCR is very important today as to how we will move forward with this patient. This is for triple negative, and this is for luminal B as well, if you are still contemplating if this is a luminal B. So there is a significant and a lot to be said about PCR in these patients. So yes, go to neoadjuvant. So if we will go to neoadjuvant, we have a lot to discuss about treatment fine-tuning. First of all, do you want to give carboplatin or no carboplatin? We do not, let's just bear in mind, in all the data, I will go very rapidly and swiftly into the data of triple negative breast cancer neoadjuvant treatment. We do not have very good expression or of low ER low patients in these clinical trials. Most of the trials were run before the definition was solid and at the time of enrollment, okay? So we have had this conflict of platinum. I think it's now settled more or less towards the use of platinums in triple negative breast cancer. So these are the major two trials before the Brightness trial, and they were both positive for PCR. The JUPAR-62 was positive for the event-free survival, while the CALGB was negative. However, I just want to tell you that they did include those patients with ER low. And if you look at the meta-analysis by the ESMO, you will find that it was positive towards the use of platinum. And since all of these trials were published in the early 2000s, most probably these patients were enrolled within the definition of an expression of 10% to define triple negative breast cancer. So I don't think we should really hold back with the platinums if you think that the patient really has an advanced disease. Okay, what about immune checkpoint inhibitors? I think Dr. Sabri elaborated very nicely on this point. I'll run and remind you just to have a quick eye. Now, in triple negative breast cancer, we all know the data for immune checkpoint inhibitors, and the most solid and rooted is that for the KEYNOTE-522. And the KEYNOTE-522 is for really triple negative breast cancer. It included only triple negatives. It was positive for PCR, event-free survival, and of course, in the last ESMO, we have had the overall survival data. However, this was pure triple negative. So if your patient is under an umbrella of private insurance, you will never get your hand on pembrolizumab for that patient. Now, we might have an outing through the KEYNOTE 756, which was just presented by Dr. Sabri for his patient, where this time we are using pembrolizumab in the hormone receptor positives. And actually, this is the nicest trial that pinpoints beautifully the ER low. Only 5% of the patients enrolled had ER low expression, less than 10%, but they beautifully elaborate how good these patients fare. Now, the trial was positive in its first primary endpoint, the PCR, with a 24% versus 15% PCR rate. But look at those patients who had ER low disease. The ER low disease had a 57.6% PCR rate. And this is a number that I think we all know we never see except with triple negative breast cancer. Of course, keeping aside the HER2. So this is a doubling of PCR if we compare the ER low with the ER positives, more than 10%. So this gives us more ground to use pembrolizumab. We don't yet have an approval, but once we get it, we can use it. However, we will still have this little problem of the early ER low, T2, T1, T2, and node negative, because these were never enrolled in this trial. I think the checkmate also, Dr. Sabri mentioned, but the checkmate does not pinpoint the ER low that beautifully. They enrolled only the ER low with high grades of expression, I think, but they did not show them that they did not really highlight their outcomes as much as in the keynote 756. Okay, what about adjuvant endocrine treatment? Then now, ever since the introduction of the definition of 10%, before the cap, people have many actually guidelines were not really looking at the addition of endocrine treatment. However, I think most of those working with breast cancer, and I would say one of them would be me, we all feel that endocrine treatment is a very mild treatment. It doesn't have a lot of implication when it comes to adverse events. So usually we give it to the patients even with the low expression. Now, this is one of the trials. It was a bit of a buzz for those who do not believe in endocrinal treatment in the ER low expressors. This, of course, it is also a retrospective trial, but it looked at patients, I think something like 7,000 patients with ER low expression. Half of them did not receive endocrine treatment. And at 3 years, at 2 years, the overall survival was 94%. At 4 years, it's 87.6%. And the risk of progression for those patients who do not receive endocrine treatment was about 25% without the use of endocrine treatment. It is retrospective, of course, but it still tells you, okay, maybe you should not really throw out the endocrine treatment that easily. At least counsel your patient, at least be frank with your patient, tell her we do not have a lot of evidence to support the use of endocrine treatment, but it is a very mild treatment. If you can really tolerate the treatment, I would definitely endorse the use of endocrine treatment. And to be quite honest, if this patient does not tolerate, I'm not that much sticking on doing a lot to keep her or maintain her on the endocrine treatment. Finally, for the high-risk patient, can we use PARP inhibition or not? Okay, the simple answer would be, with the Olympia trial, we have the triple negatives and we have the hormone receptor positive. We can easily use the PARP inhibition, but please remember, the triple negatives were included only if they did not achieve PCR or starting from any node positivity or T2. While the hormone receptor positives, to be enrolled, they had to have a very high risk or high burden disease. This means, again, like with immune checkpoint inhibitors, if you have those patients with a bit of early ER low disease, you do not easily have access to PARP inhibition. Another reason why we should all think more and endorse into the use of neoadjuvant treatment in these patients. So if the patient does not get into PCR, you can retest your residual. It's triple negative, go ahead and go into PARP inhibition. If it's luminal, okay, maybe there was a heterogeneity of the disease, and this will give you more reason to stick to your endocrine treatment. So a re-look in these patients at the immunohistochemistry will never go to waste. Finally, what to do with the CDK4/6 inhibitors? I think this, I have 2 slides. With the CDK4/6 inhibitors, however, because more or less the CDK4/6 inhibitors, they work like chemotherapy. We expect that they do work. Nice thing about the abemaciclib in the Monarch-E trial, they used the cutoff of 10%. So actually the ER low were included in the trial, and we can use abemaciclib easily in ER low disease. So thank you very much, and that is it.
Thanks دكتور شيماء. دكتور صبري. أنا عارفة والله. أنا بقول لحضرتك دكتور صبري اتفضل.
شكرا دكتور شيماء. يعني we are in the same page in our lecture, and thank you. Actually, in the early release of Keynote 532, we see that many clinicians overworld strictly to the triple negative disease. Over time, in the guideline itself, they added capecitabine plus pembro in the non-responder.
Sure.
And last guidelines in the ESMO, they added capecitabine plus PARP inhibitors plus pembro in the adjuvant setting for the patient didn't achieve a PCR or patient achieving PCR. So in the keynote itself, they are not strict at the start. Nowadays, they are adding adjuvant treatment plus pembro in the non-responder for the keynote 52. And actually, we found that many experts overworld using pembro for the patient with ER positive between 1% and 9%. It's an expert opinion, but in the reality, actually are right. They are not allowed to give pembro in the patient with ER negative tumors or ER low tumors, not negative. But in the real practice, we have now solid data from Keynote 756 and Checkmate that we can use new adjuvant checkpoint inhibitors plus chemotherapy, keeping with data from SPY2 trial, because the SPY2 trial, they gave pembro plus neoadjuvant based on molecular assessment, mama print score high,
Yes.
can receive can benefit from adding Pembro plus chemotherapy, keeping with this trial. And this was phase 3 randomized trials. I know that's not standard of care, but maybe a step to encourage patients to receive these treatments.
Yes. To be quite honest, if the patient is it's in a private practice, if the patient is out of pocket, I will be quite frank with the patient and tell her, despite not being within the label of the drug, I do believe that you will definitely gain benefit. But if the patient really needs to be aligned within her healthcare system, there are some things that you can try to do to potentiate her position. First of all, sometimes I go to try to biopsy another site. Sometimes a patient has a lymph node. We do a biopsy of that lymph node, or sometimes I just ask the radiologist to do several biopsies from the same primary tumor. Also, I heard from one of the German group, and the German groups, the way they do it is they run all the patients into the ADAPT trial, where they are testing for endocrine sensitivity. And despite knowing quite well that the patient will not be endocrine sensitive, the point is after 3 weeks of endocrine treatment, they rebiopsy, most probably the patient will have ER negative disease. The problem here is if you have a patient with inflammatory breast cancer or really advanced breast cancer, you don't really have the luxury of those 3 weeks. So I'm totally with you on the same page, yes, but sometimes because of the restrictions, we have to run around and look for reasons how to put the patient into her treatment.
Also, the rebiopsy is a very intelligent way to retesting, because in our practice, we found that patients, when I do a retesting of ER status, we have a ER positive, strongly positive. It's maybe come from tumor ischemia. You know that if the pathologist in the room now can tell us that if we have an ischemia in the operation, we can have false ER negative tumors.
Yes.
If the tumor become vascular and you keep seconds from taking a biopsy from ligation of blood vessels or ligation of tumor to be specifically within seconds to be in a paraffin block, it will be a very sensitive ER, because the ER receptors are very sensitive to ischemia. So in our practice, I found many patients repeat the biopsy from non-ischemic site, and preserving the processing within seconds from the biopsy. We take another reading from ER low to ER high.
Yeah.
Thank you.
Totally agree. Thank you, Dr. Sabri.
Any other comment? Thanks, Dr. Shimi.
Now it's my pleasure to introduce Dr. Abdelhamid Fouad, Professor of Medical Oncology, Bahia Hospital, and Lecturer of Medical Oncology, National Cancer Institute. And now he will talk about the current treatment paradigm for HER2-low metastatic breast cancer AstraZeneca Symposium. Please, Dr. Abdelhamid.
السلام عليكم. ميرسي دكتورة نيرفانا على المقدمة و thank you chairman. I would like to thank you Dr. Amani و Astra for this lecture. I also would like to thank Dr. Maya and Dr. Sarah, my colleagues, that they pave the way for me and will make my life easy in my presentation. My presentation is the current treatment paradigm for HER2-low metastatic breast cancer.
The voice is very low.
Okay. مش عايز ابقى كده كويس. Thank you. This is my disclosures. As we all know, the HER2 testing algorithm, as mentioned previously, based on immunohistochemical testing, and it classifies the patient with breast cancer to immunohistochemistry 0, that there is no staining or faint staining, incomplete staining in less than or equal 10% of the cancer cells. HER2 immunohistochemistry 1+, there is faint incomplete staining in more than 10% of the cancer cells. And immunohistochemistry 2+, there is weak to moderate staining in more than 10% of the cancer cells, and at last intense staining in more than 10% of the cancer cells, that is immunohistochemistry 3+. Based on these results, breast cancer patients are categorized to HER2 negative, immunohistochemistry 0, 1+, and if they are 2+, an in situ hybridization testing should be done and if it is negative, so it is HER2 negative. If it is positive, it is HER2 positive, and the 3+ are HER2 positive. This is the old pie chart of the breast cancer patients. They are dividing patient to HER2 positive, that represent almost 15 to 20% of patients, and all the other patients were considered as HER2 negative, based on the last slide. Unfortunately, HER2 negative are not, as we saw, are not one group. They are heterogeneous group. Patients may be having no staining or less than or equal 10, or faint staining or moderate staining. So they have variable HER2 expression. It's not intensified, but some cells may have some tumors and some with different presentation. Through the period where trastuzumab was approved for treatment of HER2 positive breast cancer patients, since its approval, these anti-HER2 targeted therapies were not effective, were not used in treatment of patients with HER2 low expression. And there was always a question, based on these different expressions, anti-HER2 therapy could be used at some time in treatment plan of this category of patients. As we all know that breast cancer is subdivided into the hormone receptor positive HER2 negative, and hormone receptor positive HER2 positive, and hormone receptor negative HER2 negative, and the HER2 enriched hormone receptor negative HER2 positive. The breast cancer with hormone receptor positive, as seen in this slide, represent almost 80% of breast cancer patients, with different behavior from one disease to another. And for a very long time, the systemic therapy for patients with hormone receptor HER2 negative was the standard of care was upfront endocrine therapy, which was the preferred option. And in some scenarios, we may use chemotherapy in case of visceral crisis, or in some situations, plus or minus targeted therapy in some cases if they have targetable mutation. And at some time, those patients will progress, and usually we go to systemic chemotherapy for most of the patients. This is the guidelines, the NCCN and the ESMO guidelines. As we can see, in the first line therapy of hormone receptor positive HER2 negative metastatic breast cancer, the first preferred first line option is a CDK plus endocrine therapy or plus fulvestrant, unless there is a visceral crisis. And this is also an algorithm. If the patient was diagnosed in the first line treatment to have hormone receptor positive HER2 negative, the preferred option is endocrine therapy, unless he has visceral crisis. The endocrine therapy, as we all know, pre or post-menopausal, we receive if the patient is premenopausal, ovarian suppression plus endocrine therapy plus a CDK4/6 inhibitor. In the post-menopausal, endocrine therapy plus a CDK4/6 inhibitor. Most of the patients will develop resistance to endocrine therapy and will need a second line therapy, which was clarified in Dr. Maya Isa presentation. But through the trials that contain targetable or PIK3 mutation or ER1 mutation or BRCA mutation, most of these trials give non-durable progression-free survival, and most of them was not reflected to overall survival benefit. The median progression was low, from 6 to maximum 10 months, making an unmet need for this patient that progressed on a CDK4/6 inhibitor. And the other category of patient, if he has visceral crisis, also upon progression, he usually receive multiple lines of chemotherapy, and also the median progression-free survival is usually low. So to revise those patients when develop endocrine resistance, usually maybe it is primary resistance or a secondary resistance, depending on the duration of hormonal treatment that he's received. If within the first 6 months of treatment, usually it is named primary resistance. After 6 months to end of hormonal treatment, it is a secondary resistance. And as we mentioned, those patients until very soon usually receive subsequent lines of hormonal treatment or targetable treatment if they have mutation, or chemotherapy, and the progression-free survival is not that good, not satisfactory. It is an unmet need, and there is a need to improve this gap or this patient response after progression to a CDK4/6 inhibitor. And we highlighted that those patients with hormone HER2 negative, they are a heterogeneous group, not one group. Some of them are HER2 pure negative, some have low HER2 expression. And for a long time period, anti-HER2 targeted therapies were not used because they were not effective. They were used only for the HER2 amplified tumors. And also after progression to CDK4/6 inhibitor, most of the trials and real-world data suggest a PFS around 4 months with after progression to a CDK4/6 inhibitor. Based on these informations and the advances in the immunohistochemically testing, a validated test, the old categorization of HER2 negative patients were recategorized into patients with HER2 0, HER2 from more than 0 to less than 10% or equal in complete staining, or patients with immunohistochemistry 1+, or equivocal that need a validated test by in situ hybridization or intensified. And based on this, there is a new subset of patients that are termed HER2 low. And HER2 low mean patient with immunohistochemistry 1+, or he has 2+ with a negative in situ hybridization testing. And we have to know that 60% of these patients that were deemed to be HER2 negative have low expression, of low levels of HER2, which can be used in the clinical practice as a targetable target for new medications. And the guidelines is recommending to test for all patients either newly diagnosed or having a new relapse or develop metastasis during their treatment course, because the HER2 usually change, making the express HER2 low with progressive expression of the HER2 low, of the HER2 receptors. But how can we define HER2 low? Either it is a static definition or a dynamic definition. A static definition, we mean that if the patient is diagnosed upon the first presentation with HER2 low, at the first presentation, so it is HER2 low. And if he has HER2 negative, it is HER2 negative. And if he has amplification of the HER2, it is amplified. We know from practice and from several trials that the HER2 status may change. So we have the other dynamic definition. Should we re-biopsy, as discussed with my previous colleagues, should we use new biopsies to recheck on the HER2 status? The practical definition of HER2 low is giving the complexities of HER2 low pathological definitions and some suggestions that the TDXD or the new generations of the ADCs, as we will show in the next slides, even in HER2 0, they have some activity. So HER2 low means HER2 non-amplified. They have no amplification of the HER2 receptor that show low expression of HER2 in the previous biopsies or any biopsy done through the course of treatment of the patient. And as we can see, they are dynamic. Sometimes the tumor is HER2 negative, then upon progression or upon having some resistance to endocrine treatment or even to chemotherapy, HER2 levels are increased. The rate of HER2 low tumors increases progressively with additional biopsies. And this is a very practical point. We have to re-biopsy, especially if we have an early resistance to the endocrinal therapy. Trying to pick which patients that should we suspect to have a HER2 low. HER2 low tumors usually are present in patients based on the pooled analysis of 4 GBG trials and the National Cancer Database as shown. It's more common in patients with hormone receptor positive than hormone receptor negative. It's more common in grade 3 tumors more than grade 1 and grade 2. More common to see HER2 low in patients with elevated Ki67. After all that we have said, the new pie should be changed, not HER2 positive 15 to 20%, and the other patient should be HER2 negative. Now we can say that we have HER2 positive, HER2 low that represent about 50% of the patients, and HER2 negative that represent 30 to 40%. And among the patients with HER2 low, we have 60% of them with hormone receptor positive and about 40% of them with hormone receptor negative. As we mentioned, this is an unmet need after progression in hormone receptor positive patient to CDK4/6. An effective drug was not available till the data from the DB04 trial that we will discuss in a second. The idea of ADC, directed delivery of cytotoxic agents, is that we have a drug that binds to a specific receptor in the tumor cell, and after binding to this specific receptor, these ADC and the receptor are internalized inside the cells, and this ADC is degraded in the lysosomes. Then there is release of the payload or the cytotoxic agent in the intracellular agent that lead to the DNA damage and killing of the tumor cells. And most of the first generations of ADCs have this mode of action only. They can target the cells that have the receptor, then they are non-effective after that. But the new generations of ADCs can work by another mode of action, which is the base standard effect, that they are membrane permeable and can go to the neighboring cells by diffusion, even if these cells are not expressing the specific receptor that is needed for the first time to bind. As we see here, this is the bystander effect, and this gives more potency to the ADC that kill the cells that have the specific receptors and the neighboring cells in the tumor environment that lack these receptors. The trastuzumab deruxtecan have this mode of action, the bystander anti-tumor effect. The TDXD is a high potent ADC. It has a payload, this high potent topoisomerase 1 inhibitor. Has a cleavable linker that can be easily go when degraded from the antibody, and have high antibody drug ratio, have high ratio of the payload, and work by the bystander effect as we discussed. The TDXD shows some efficacy in heavily pretreated patients with hormone receptor positive and HER2 low patients. In this trial, it contained 54 patients with heavily pretreated. Median lines received was 7.5 line. The overall response rate in these heavily pretreated patients was 37%. And the median PFS in also, again, these heavily pretreated patients was 11 months. Based on this mode of action and this idea, the Destiny Breast 04 was done. This trial is done to evaluate the efficacy and safety of the TDXD in this category of patients that expressing the HER2 low, meaning immunohistochemistry 1 plus or immunohistochemistry 2 plus with in situ hybridization negative patients. The TDXD HER2 directed antibody drug conjugate that target the tumor cells with HER2 low expression and also by bystander effect in the neighboring cells. This is the study design, including patients with HER2 low, receiving 1 or 2 lines of prior chemotherapy, and they allow patients with hormone receptor disease after being hormone refractory and include patients receiving CDK4/6. And they randomize patient in a 2-to-1 fashion, TDXD versus the treatment of choice according to the primary treating physician. The primary endpoint was the PFS in the HER2 positive population by blinded independent review. This is the inclusion criteria of the trial, and this is the patient characteristics. As we can see, it contains patient with HER2 low 1 plus and 2 plus. It contained most of the patients were 90% hormone receptor positive and also 10% triple negative. Most of patients received 3 lines, including 2 prior lines of endocrine therapy and 1 line of chemotherapy, and also 70% of the patient received CDK4/6 in the previous lines. This is the curve of the primary endpoint on the left. Patient with hormone receptor positive, the median PFS was 10 versus 5.4 months with a hazard ratio 0.51, and we can see the curves separate nicely. And the trial meets its primary endpoint. Also, all patients show benefit from the TDXD versus the treatment of choice. The updated analysis of the trial showed also maintained response after a longer follow-up. The patient is still having 9.6 month median PFS versus 4.2 months, and in the hormone receptor positive and also in all patient groups. So also in terms of overall survival, there was overall survival benefit in the primary analysis and in the updated analysis in HER2 positive cohort and in all patient groups. In HER2 negative, although they were 10% only, also there was benefit in this subgroup of patients that are HER2 low and hormone receptor negative. TDXD was effective in all subgroup of patients, even with hormone receptor negative in the upper waterfall plot curve, and also in the hormone receptor, either they were immunohistochemistry 1 plus or 2 plus with negative in situ hybridization, and no difference in response between these two groups. Going to the patient with brain metastasis, usually most of the trials exclude this subgroup of patients because these patients have a dismal outcome and poor prognosis. They were excluded from most of the trials. In DB04, they included patients with stable or asymptomatic brain metastasis that they do not require rapid treatment. And the subgroup analysis of these patients that received the TDXD versus the physician choice of treatment, the patient have overall response rate 25% versus 0% in favoring the TDXD. And the clinical benefit rate also was superior, 58% versus 18%. Favoring TDXD, and the disease control rate was also in favoring the TDXD, and we have 16.7% in the patient receiving TDXD with complete response in the brain metastasis, which usually we don't see this response previously with other drugs, even the CDK4/6 inhibitors. The median PFS for patient with brain metastasis was 9.7 months receiving TDXD, and the median OS was 16.7 in this patient with aggressive disease biology. And upon progression with patient with brain metastasis in the TDXD arm, they found that most of the patients, up to 62.5% of these patients, has progression extracranial with good control of their brain metastasis. Regarding summary, the median time of duration for the TDXD arm was 8.2 months versus 3.5 months for the patient that received chemotherapy. And about more than 15% of the patient receive treatment more than 18 months in the TDXD arm versus 1.2 in the chemotherapy arm. The most common adverse event that lead to treatment discontinuation was interstitial pneumonitis and peripheral neuropathy in the patient receiving TDXD. And the most common adverse event lead to dose reductions was nausea and decreased platelet count in the TDXD arm versus hand and foot syndrome and neutropenia in the chemotherapy arm. The exposure adjusted incident rate for any adverse event grade were 1.2 for the TDXD arm versus chemotherapy 2.6, and this means longer exposure or longer duration of treatment with TDXD does not increase the rate of adverse events. And overall, the safety of the updated analysis was similar to the adverse events of the primary analysis, and this means longer duration did not lead to more adverse events in prolonged duration of treatment. As we see here, this is the adverse event of special interest, this interstitial pneumonitis. We have grade 3, 1.1%, and it's not transferred, all the adverse events will not transfer to death except the same percent of grade 3. And I strongly recommend the strategy of Dr. Sabri, the 5S strategy, as Professor Sabri mentioned. We have to early screen and do scans and communicate with a pulmonologist, because this, and steroids early as we can, because these differ in the prognosis of patients with interstitial pneumonitis. Left ventricular dysfunction was also acceptable, and the updated analysis also confirmed the same adverse event in the primary analysis. No new cases with interstitial pneumonitis were seen since the primary analysis. The conclusion of the DPO4 trial that after a median follow-up of 32 months, confirmed, this trial confirmed the sustained clinically meaningful improvement of response and progression-free survival and overall survival for TDXD versus chemotherapy in HER2-low metastatic breast cancer patient, regardless the hormone receptor status. Also, patients with hormone receptor negative benefit from the drug, and although they were only 10%. Patient with intracranial or brain metastasis and this aggressive patient disease, the patient have better overall response, disease control rate, and clinical benefit rate. Median PFS for this patient was 9.7 months. Median overall survival was 16.7 months. With a longer duration result of the updated analysis, the overall safety profile of TDXD was acceptable and generally manageable, and with no new adverse event other than seen in the primary analysis. Based on this trial, this drug, the TDXD, was approved in the second line after progression to chemotherapy in hormone receptor positive HER2 negative, with a very good results. Whatever the patient has a targetable mutation or progressed on early on CDK4/6 inhibitor, most of the patient benefit, and this also with hormone receptor negative HER2-low. Also, it is recommended to give in the second line setting. To conclude, HER2-low is a heterogeneous disease. The Destiny B04 demonstrated superior PFS OS in patients with HER2-low metastatic breast cancer treated with TDXD versus physician choice of chemotherapy in the primary analysis and also in the updated analysis. And the Destiny Breast 04 established HER2-low metastatic breast cancer as a new targetable patient population and fill the gap that was for a very long period of time not filled with different categories of treatment after progression to CDK4/6 inhibitor in the first line treatment setting. With longer treatment duration, the overall safety profile of TDXD was acceptable and generally manageable and consistent with the primary analysis. And thank you for your attention. Thank you.
Thank you so much, Dr. Abdelhamid, for the very elegant presentation as usual. Is there any question from the floor? Thank you so much, Dr. Abdelhamid.
It's my pleasure to introduce Professor Dr. Ahmed Al-Bastawisi, Professor of Medical Oncology and CI. He will talk us about Keytruda, a new hope for survival in triple-negative breast cancer. Please, Dr. Ahmed.
Thank you, Professor Jihan Sha'rani, for your kind introduction. I would like to thank all the team of MSD for inviting me, and my talk is titled A Game Changer, Keytruda, a new hope for survival in early triple-negative breast cancer. So this is the outline of my presentation. I will start with a short introduction, then I will go through the evidence for pembrolizumab in early triple-negative breast cancer, and finally conclusion. If we look at some data about breast cancer, we know that it is the first common malignancy worldwide, and if we look at the Globocan data, we have more than 2,002,100 new cases in the year 2020. Out of these cases, we have around 7% cancer-related deaths, with around more than 600,000 deaths per year. If we look at the highest incidence worldwide, in the Americas, we have the United States as the most frequent malignancies, in Europe, Belgium, in Asia, Singapore, whereas the highest incidence in Africa is in Somalia, and in Asia is unfortunately in Syria. Regarding the stage at diagnosis, we have around 2/3 of cases diagnosed as early stage, and we have 99% survival rate if we are diagnosed in the early stage. So we definitely need to be diagnosed as early as we can. If we look at Egypt, we have around 22,000 new cases per year. Out of these cases, we have more than 9,000 deaths per year. If we look at the definition of triple-negative breast cancer, we know that 75% of breast cancer patients are HR positive, and around 20% are HR negative, are HER2 negative, are HER2 positive, whereas around 15% are triple-negative disease, and 10% of patients are both HR positive and HER2 positive, and this is why the incidence for HR positive disease is around 65 up to 75 disease. What are the clinical characteristics of triple-negative breast cancer? We know that it is unfortunately occurring in younger population, and usually a more aggressive disease. And if we look at the right side of the screen, if we look at the relapse pattern of triple-negative disease, it has a unique characteristics. For example, the highest incidence of relapse is occurring in the first 3 years as compared to other types of breast cancer, but the incidence drops very sharply after 3 years and much more after 5 years. And if we look at the right side of the curves, the survival curves for triple-negative breast cancer is almost parallel to the baseline as compared to HR positive disease, which is characteristically can relapse regardless of the timing, even after 20 or 30 years. What about neoadjuvant chemotherapy? When we achieve pathological complete response, we have data that this pathological complete response is well correlated with event-free survival as compared to patients not attaining complete pathological response. But what is the best regimen for neoadjuvant treatment in triple-negative breast cancer? We know that the addition of carboplatin to the standard neoadjuvant AC taxanes in triple-negative breast cancer can increase the pathological response, and we have data for that, raising the pathological complete remission rate from around 35 to around more than 50%. But what was conflicting is this elevation in the incidence of pathological complete response is well correlated with the event-free survival. We have conflicted data before brightness trial. Some were significant and some were non-significant, but the change in our concept about the correlation between complete pathological response and the event-free survival in triple-negative breast cancer disease didn't occur until the brightness trial. And this trial was not initially intended to assess this question. It was designed to assess the value of a PARP inhibitor, which is veliparib, in patients who are more than 18 years, histologically or cytologically confirmed stage 2 and 3 triple-negative breast cancer, ECOG performance status of 0 to 1, and patients were candidate for curative surgery with documented germline BRCA mutation status, and the patients were receiving paclitaxel carb in one arm plus veliparib, and the paclitaxel carb veliparib as a placebo, or paclitaxel carb placebo and veliparib, and the segment 2 of the treatment was AC in the standard regimens. 2 to 8 weeks after that regimen, surgery was done. And if we look at the results, the above two curves is the use of paclicarb plus or minus the PARP inhibitor, which was the initial intention of the trial, and we can easily notice that no overlapping more than that, which denotes that the PARP inhibitor was not beneficial. But what we benefited from brightness trial is that paclitaxel carb is superior to paclitaxel as single agent regarding event-free survival, which is making us more confident that the addition of carboplatin is associated with a more increase in event-free survival. And based on that, carboplatin is a standard of care in stage 2 and above early triple-negative breast cancer disease. And if we look at the event-free survival by pathological complete remission in all patients, and regardless of positivity or negativity of germline BRCA mutation, all are in favor of the addition of carboplatin, whereas the overall survival was not meaningfully significant for this clinical trial. But at least we benefited from brightness, is that we are having a new weapon for early triple-negative breast cancer, which is carboplatin. But why to add immunotherapy for early triple-negative breast cancer disease? Biologically, we have data that basal-like or triple-negative breast cancer disease, as compared to others, is more having tumor-infiltrating lymphocytes, expresses PD-L1 much more than others, and the number of mutations is more as compared to others, which makes triple-negative breast cancer disease a good candidate for incorporation of immunotherapy in the treatment regimens. And based on that, the Keynote 522 clinical trial was initiated, and here I will show initially the data presented in the ESMO 2021. And this clinical trial was incorporating patients with stage newly diagnosed triple-negative breast cancer of either T1C N1-2 or T2-4 with N0 up to 2, ECOG performance status of 0 to 1, and availability of tissues for PD-L1. And the patients were randomized in a 2-to-1 fashion to receive either carboplatin, paclitaxel, doxorubicin, cyclophosphamide, the standard, plus or minus pembrolizumab, with a maintenance arm for pembrolizumab after surgery to continue for 1 year. If we look at the baseline characteristics, the median age was 49, 48. respectively in both arms. And what is more important is the incidence of PD-L1 positivity it was more than 80% in both arms. Again, a slim majority of patients received weekly carboplatin, and the tumor size was T1 to T2 in 3/4 of patients, which denotes that the tumor was not a higher stage. The inclusion criteria was not for higher stages only, and the lymph nodes was almost equally between positivity and negativity for both arms. The initial data for the value of pembrolizumab in early triple-negative cancer was presented in ESMO 2019 when it showed an improvement of pathological complete remission rate of 51.2 versus 64.8% with a delta of around 13.6%. And then in 2021, there was a separation of event-free survival data in favor of the addition of pembrolizumab in early triple-negative. But if we look at interim analysis there was a statistically significant and clinically meaningful improvement in event-free survival. It was improved from 15.7 to up to 23.8 with a significant hazard ratio of 0.63, denoting around 37% decrease in the incidence of occurrence of event or death with the use of pembrolizumab in early disease. Fortunately, the incidence of distant recurrence was in favor of the addition of pembrolizumab, 7.7% versus 13.1% with chemotherapy alone. So we are sparing more patients in early triple-negative from experiencing distant metastatic disease where the disease is definitely incurable. If we look at the predefined subgroup analysis, we can easily notice a value for the addition of pembrolizumab regardless of whatever subgroup, regardless of nodal status, positive or negative, regardless of tumor size, and regardless of the carboplatin schedule, regardless of age, performance status, but most importantly, regardless of PD-L1 positivity or negativity. The patient will benefit from addition of pembrolizumab, and so it is used in regardless to PD-L1 positivity is not a prerequisite for pembrolizumab in early triple-negative as compared to metastatic disease in which PD-L1 positivity is mandatory. A lot of debates about the value of pathological complete response and the value of event-free survival, because if we look at event-free survival in patients attaining a complete pathological response, the curves are almost near to each other with a 2% difference in favor of pembrolizumab, but the curves are more separating if the patient didn't attain complete pathological response. However, those who are pro of the use of pembrolizumab, regardless of pathological complete remission, are telling it's okay. The value was attained from neoadjuvant to adjuvant, so we cannot separate the neoadjuvant to adjuvant arm. Again, if we have even 2% with longer follow-up, we may have wider separation of the curves. And more importantly, if we look at the hazard ratio for both patients attaining pathological complete response and not attaining a complete pathological response in both, the hazard ratio is 0.7, which simply means that the value is around 30%, regardless of attaining or not attaining complete pathological response, so equal in hazard ratio. At that time in 2021, the overall survival curves started to separate, but it was not yet reaching the statistical significance difference. And if we look at the adverse events are much more important in early disease, because we are talking about a potentially curable disease, and we know that some of the immunological adverse events are very long life, like the endocrinal adverse events. If we look at the neoadjuvant versus the adjuvant setting, if we look at the combined phases, the incidence of all treatment-related adverse events was higher in the pembrolizumab-based arm, around 27% versus 14%. And again, the immune-mediated adverse events was higher, around 10.9 versus only 2.8%. But look at the adjuvant phases in both arms, it is much more decreasing to the incidence of 4% for the treatment-related adverse events and only 1.5% 4% for immune-related adverse events, denoting that even the immune-related adverse events are fading with time. Based on that, FDA approved Keytruda for the use of neoadjuvant adjuvant setting for 1 year in high-risk early-stage triple-negative breast cancer disease, and it was a very important landmark in the treatment of early triple-negative breast cancer disease. Again, if we look at the long-term data for the keynote for event-free survival, look at the initial interim analysis for the difference, as I said, in progression-free survival was in the range of around 8%, 84.5% versus only 76.8%. But if we look at interim analysis 2, the curves are starting to separate much more than the interim analysis 6. We are now approaching around 9%. More importantly, if we look at the debate of whether to go for pembrolizumab in patients attaining a complete pathological response or not to go for that, look at the initial interim analysis for the difference, as I said, for patients with a complete pathological response was only 2%, and it was much higher for patients with non-complete pathological response, although the hazard ratio was the same. But look at the right side of the screen for interim analysis 6. The difference, even for patients with complete pathological response, starts to be separating more widely, and the difference now in patients with complete pathological response is 4%, as compared to only 2% in the initial analysis, and definitely for patients with non-complete pathological response, we're still gaining benefit without debates. So as the investigators were arguing about the value in patients with complete pathological response, the curves, yes, started to separate. And we concluded from this interim analysis that we have now a strong evidence, because after a median follow-up of more than 5 years, the neoadjuvant pempo chemo followed by adjuvant pembrolizumab continued to show a clinically meaningful improvement in event-free survival as compared to neoadjuvant chemo alone in high-risk early-stage triple-negative breast cancer disease. And this benefit was consistent with the pre-specified subgroups, including those with PD-L1 positive or PD-L1 negative, and more importantly, if we look at the event-free survival in patients with complete pathological response, it is around 4 percentage points and 10.3% in patients without complete pathological response. At that time, the follow-up of overall survival was continuing, but separation of the curves in favor of pembo in the event-free survival, whether attaining or non-attaining complete pathological response, added to our confidence about the use of pembrolizumab in early triple-negative breast cancer disease. But perhaps the dramatic change in triple-negative breast cancer disease didn't occur until the last ESMO around 1 month ago, when the overall survival data of Keynote 522 was presented. Because fortunately, look at the overall survival curves, it was now positive. The median overall survival, and after 5-year follow-up, was around 21.8%. It was around 86.6% for pembrolizumab-based arm and only 81.7% for the chemotherapy-only arm, which simply means we are saving 5% more of our patients. And as we were encountering in event-free survival, look at the overall survival subgroups, regardless of whatever, regardless of positivity or negativity of lymph nodes, regardless of tumor size, regardless of carboplatin schedule, whatever the age, and more importantly, whatever the PD-L1 positivity or negativity, all the events are in favor of the addition of pembrolizumab regarding overall survival in early high-risk triple-negative breast cancer disease. And once again, we are going to the debate of whether to continue treatment after attaining a complete pathological response or not. Look at the overall survival by pathological complete response. The above two curves are almost near to each other. We have 95.1% for pembrolizumab based arm and only 94.44 for chemotherapy only arm. So the difference is less than 1%. Whereas if the patient is attaining a complete pathological response, it is 71.6 versus 65.7. So no debates at all for patients attaining attaining no complete pathological response. The debate continues regarding whether to go for pembrolizumab if the patient is not, if the patient is attaining a complete pathological response or not. Those who argue that we should continue are arguing that, okay, yes, the curves are near to each other, but it is still too early. And as our experience with event-free survival curves, it started by 2%, but with longer follow-up in the interim analysis 6, it is now 4%. So why not more follow-up maybe in favor of wider separation of the overall survival curves? And those who are against that concept are arguing that we are now having a 5-year overall survival follow-up. And as we know, in triple-negative breast cancer disease, the highest incidence of relapse occurs after 3 years, much more after 5 years. So after 5 years, the follow-up, the number of expected events is not that high. So they do not expect wider separation of the curves. Again, the argument is, okay, you are telling me that you do not benefit from adjuvant arm, but the data are coming from neoadjuvant arm. And actually, we didn't have a second randomization. Perhaps this solution should have been solved if we have second randomization, which means patients attaining, for example, complete pathological response to be randomized to receive pembrolizumab or no pembrolizumab. At that time, I can answer the question. And fortunately, we have 2 clinical trials from the academia to test this concept, and we are eagerly waiting for that. Again, we can go by the debate to further issues because, okay, you are telling me that the debate is for patients attaining complete pathological response, but I can tell you, even in patients not attaining a complete pathological response, we have wider separation of the curve. But is this separation attributable to the neoadjuvant adjuvant, or is it attributable to the neoadjuvant only arm? Who can tell that we will not have this separation if we have only neoadjuvant without adjuvant? Again, we are waiting for the 2 clinical trials which are testing the concept of randomization of patients attaining a complete pathological response after for the adjuvant setting. And again, we are in a bad need to more predictive markers to assess who will benefit from that treatment in the adjuvant setting. And why all that debate? Because as I told, we are talking about a curative intent population. So the adverse event is more important in the curative intent setting because as you know, the immune-related adverse events, yes, in the adjuvant setting is much low, but imagine if you are having, for example, type 1 diabetes as immune-related adverse event, which is lifelong in a patient who is supposed to be cured and will forever receive insulin for his life. So it is much more important to reach a solution for the adjuvant arm. However, up till now, the standard is to go for neoadjuvant treatment, and the guidelines is for neoadjuvant adjuvant arm for 1 year because the evidence up till now is supporting 1 year of pembrolizumab in the neoadjuvant adjuvant setting. So to conclude, we are really having exciting time for early triple-negative breast cancer, and definitely Keytruda is a game changer in high-risk early triple-negative breast cancer. And with this, I thank you for your attention.
Thank you so much, Dr. Ahmed. Is there any question from the floor? Dr. Ali?
Professor Dr. Ahmed, thank you very much for this excellent and very comprehensive presentation about the role of Keytruda in triple negative breast cancer patients. Actually, I have two questions. The scenario for patients after neoadjuvant chemotherapy who attend incomplete pathologic response is clear regarding surgery, I'm talking. But after complete pathologic response, what is the role of surgery and what type of surgery you can offer the patient and based on what? This is the first question.
Complete pathological response?
After complete
or
pathologic.
complete clinical response, you mean?
No, complete pathologic response. After neoadjuvant therapy.
So the patient underwent surgery.
So what type of surgery? Should we offer the patient direct mastectomy or conservative surgery?
So triple negative breast cancer received pembrolizumab based and chemotherapy, and then we assessed the clinical response. And based on the assessment of the clinical response, we will go for whatever surgery based on the possibility of attaining negative surgical margin. So being triple negative disease is not a preclusion for conservative breast surgery. And then after surgery, we will assess pathological response, which may be complete or incomplete. If I understand.
It is a dilemma for complete pathologic response because you know most of the patients with triple negative disease, they are young patients. Yeah. So to offer them all after complete pathologic response mastectomy is very difficult for the patient.
Not, I mean we assess pathological response after surgery.
Yes, after pathologic response. You are not going to rebiopsy the patient after neoadjuvant chemotherapy.
No, Keynote 522 was for patients receive assessment of pathological response post-surgery.
Post-surgery only.
So regardless of the type of surgery, it was based on clinical findings.
Okay. So you mean after complete clinical response, you are going to refer the patient for surgery according to what? This is my question.
The majority according to clinical assessment. Or if the patient, if you can go for conservative breast surgery, it is the standard.
But this is the point. They are going to do conservative breast surgery according to what?
The majority of patients in the trial, we had T1, T2, and you have T3, T4, according to the guidelines for conservative breast surgery in any disease. Yes, we are more keen about conservative breast surgery because younger population, as you said, but no specific indication for mastectomy or conservative breast surgery in the disease setting.
Okay. The second question, if you have a triple negative patient and she received the primary treatment and then she developed metastatic disease, on rebiopsy, when I do rebiopsy for her, I got the results with low hormonal positive.
With positive hormones?
Positive hormone, but low, less than 10. So are you going to treat this patient as hormonal positive or triple negative patients?
So the patient is low positive, you mean?
Yes, low hormonal.
Yes, the guidelines, okay, the issue, for example, if you have low positive disease or ER negative, PR positive disease, it is considered biologically as more towards triple negative disease, especially in metastatic disease. If you are in the adjuvant setting and you have low ER.
Just a second, please. There is too much noise here in the floor. Can you please close the door? Excuse me, please. There is too much noise here. Excuse me. Can we be all with يعني ممكن نبقى كلنا مع بعض؟ معلش أنا آسفة بس عشان إحنا هنا مش سامعين حاجة خالص.
لا سيطري.
أيوة طبعا.
If you have low HR positive disease, for example, low ER or ER negative PR positive, in early setting we will go for adjuvant to hormones, but in advanced disease we will not go for the standard, which is hormonal based therapy plus CDK4/6 inhibitors, because we are biologically more towards triple negative, and we are now, this is the main treatment. In the adjuvant we are giving hormones instead of nothing, But in the advanced disease, I cannot go for first line CDK4/6 ET in a patient with low HR positive disease, because this is the main treatment. It is more towards triple negative disease. However, if you are in a place in which in order to go for immunotherapy, it should be insured, and we should stick to the clinical trial data. I cannot go for testing for PD-L1 and go for immune therapy. However, I will consider the patients more towards triple negative, and I will not depend on first line hormonal based therapy.
Okay, thank you very much.
Thank you.
And I just want to comment about the first question, Dr. Riham. It's the type of surgery. I think we all take the decision from the start before the patient begin her treatment. That if the patient we are going to do mastectomy from the start because she's not fulfilling the criteria of the conservative, like microcalcifications, like it's multicenteric disease or whatever. So we go for mastectomy regardless the response is. And please, Dr. Ahmed, correct for me. Or
no,
patient.
I'm sorry. This is not what I mean. I mean after complete response. So there is no tumor. So how the surgeon will go and decide for what type of surgery?
Professor Riham is assuming that the patient did the biopsy.
Has no.
Right?
Yes.
Yes. Many clinical trials in inflammatory breast cancer, by the way, in order to preclude local treatment if you are attaining a complete pathological response post-neoadjuvant, however, it's still investigational.
Well, actually, because sometimes in the practice, we find that from the start, we have the decision of the mastectomy, and we didn't do any clipping. And then after that, after achieving a very good response, she go to the surgeon, and he go into frozen section and to achieve negative margins, which is
the decision of surgery, of the type of surgery, is based on clinical parameters.
I think Dr. Muhammad. Okay.
Dr. Ahmed, thank you for your elegant presentation. Thank you, Dr. Riham, about your very good question about the patient have a tumor vanishing after keynote 5-2. But usually, in a real practice, we are referring to the initial imaging the patient did in the diagnosis. If the patient have inflammatory breast cancer, T4B, T4D, T4C, should go for a mastectomy, because inside the keynote 52, they have a unique pathological evaluation by a residual cancer burden for the patients. The patients should, in the initial presentation with skin disease or inflammatory disease, concerning the tumor size, not a nodal disease, should not de-escalate the surgery, because the residual cancer burden built on the how much the tumor is there after surgery. And inside the keynote 52, there are 5% of patients are a poor responder to treatment. Those patients have RCB, residual cancer burden of score 3. Those patients have a very bad prognosis even in member after surgery, but they are represent about 5% of patients in this trial. My opinion is go back to the initial imaging. If the patient initially for a mastectomy, it will be a mastectomy. If the patients have a T3 disease, you can de-escalate.
Yes, it is dependent on clinical parameters, not on pathological complete response, which was assessed post-operatively in the trial.
Last question, Dr. Ahmed. Please, is the patient lose her chance to beginning with neoadjuvant Keytruda, and we meet her after surgical? Do you recommend to do PD-L1 test immediately to start with Keytruda plus chemotherapy as adjuvant?
So the patient came to you after surgery or in the neoadjuvant?
There is no neoadjuvant.
Unfortunately, this is a very important issue in practice, because if you are not receiving pembrolizumab in the neoadjuvant, you cannot go for pembrolizumab in the adjuvant. You will go for BRCA1 and 2. If mutant, you will go for BRCA for PARP inhibitors adjuvant. If not, and the patient is not in complete pathological response, you will go for capecitabine. So, in contrary to HER2 positive disease, in which the patient, if not starting anti-HER2 in the neoadjuvant setting will be losing, but still he can go for anti-HER2 in the adjuvant setting. For immunotherapy, if the patient didn't start in the neoadjuvant setting and after the data of last ESMO, you are depriving 5% of the patients from receiving cure in early triple-negative breast cancer. So it's very crucial to discuss with surgeons and other teams in order to start neoadjuvant immunochemotherapy in the neoadjuvant starting from T2, because you are saving the lives of more patients.
Thank you so much.
Thanks.
Last question. If the patient received neoadjuvant pembro and assuming good response, but the patient is BRCA mutant, we all do now BRCA mutation for our BRCA testing for all triple negative available. What are you going to give her in adjuvant? Are you going to give a PARP and pembro together?
Yeah, we know that we do not have strong evidence for that, but the value of we were talking about the tolerability. For example, we were confronted by two situations: in triple negative with pembrolizumab and PARP inhibitors, and in the HR positive HER2 negative with CDK4/6 and PARP inhibitors in the same situation. From pharmacology, always the combination of two TKIs is associated with more adverse events, but the association of parenteral drug like pembrolizumab and oral drug like PARP inhibitor is possible, so you can go for, and we have trial for that, by the way, with either PARP inhibitor or ADC if you are not BRCA mutant. So you can combine, or you can, before ESMO, we were arguing that if you have a patient with, you have a strong evidence for adjuvant olaparib because it improves the survival. Now we are improving the survival with pembrolizumab in neoadjuvant, adjuvant, and also for olaparib. But if I started by neoadjuvant treatment, I will continue for adjuvant pembrolizumab. If the patient proved to be BRCA mutant, perhaps I will go for also for PARP inhibitor.
شكرا.
Thank you.
Now we are at the end of our session. Thanks for all respectable speakers and attendees. And now we go to MT session, last session for today. Okay.